Good afternoon. I'm John Pinney, and I'm the Executive Director of the Institute for the Study of Smoking Behavior and Policy. I want to welcome you on behalf of the Kennedy School and the Institute. I'm delighted we have a good crowd here. It seems to me that it supports our belief that tobacco smoking is a timely and important subject of great concern to the majority of Americans, both smokers and non-smokers. Our research agenda at the Institute has been characterized as ambitious. We have cast a wide net covering research issues from quitting and relapse to smoking restrictions in the workplace and in the community. Our staff and our extended family of colleagues in the Boston area include physicians, psychologists, economists, demographers, public health administrators, voluntary health agency staff members, a hypnotist or two, and a historian. Dr. Alan Brandt from the faculty of the Harvard Medical School is our house historian, and he's preparing a social history of smoking. Because this is an historic event, I asked him if he would tell us what smoking looked like in 1936, and I'd like to take this opportunity to read you his response. 50 years ago, at the time of Harvard's 300th birthday celebration, cigarette smoking was in its heyday. In 1900, smoking was still the exception to the rule, despite the growth of a major industry and the technological capacity to mass-produce cigarettes. Yearly per capita consumption stood at but 49 cigarettes. But by 1936, consumption had precipitously risen to almost 1,800 cigarettes per person per year. The rise of the cigarette marked one of the most dramatic successes of a consumer product in American history, the result of vast changes in American social and cultural life, and especially advertising and marketing. In 1936, eager listeners might tune in to the Lucky Strike hit parade or the Philip Morris Playhouse. Benny Goodman's Let's Dance could be heard on the Camel Caravan, while Glenn Miller played for Chesterfield. On the silver screen, Humphrey Bogart, Spencer Tracy, and Jimmy Cagney could rarely be found without a cigarette. By 1936, women represented an increasingly important part of the cigarette market. Radcliffe women, after an angry debate in the 20s over rules forbidding smoking, now smoke with impunity. Advertising was as aggressively pitched to women as it was to men. And by 1950, roughly one-half of all American men and one-quarter of all women were regular smokers. These numbers would continue to climb into the 1970s. But in 1936, the writing was already on the wall concerning the enormous health consequences of cigarette smoking. In that year, Johns Hopkins statistician Raymond Pearl had just begun work on a study which would demonstrate that cigarette smoking dramatically shortened life. By examining the longevity of smokers as compared with non-smokers, Pearl revealed what has become common knowledge 50 years later. In 1936, the severe toll which smoking takes was only just becoming clear. In that year, there were approximately 4,000 deaths attributed to lung cancer. By 1945, there were 11,000 lung cancer deaths. In 1986, there will be more than 100,000. Now, the marketing success that brought us the rise of the cigarette has been supplanted by a remarkable public health success, the decline of the cigarette. The benefits of this are beginning to be seen. Last December, the National Cancer Institute reported the first decline in lung cancer cases among white males reported in 50 years. Smoking is going out of style, and another series of vast changes is underway in American social and cultural life. These changes have occurred in the number and percentage of smokers and in the way we feel about smoking and the way we treat smokers. Our policies toward smoking have changed and are continuing to change, but there is much more to be done. Our panel today will discuss some of these changes and, I think, challenge us to do more. I'd like to introduce our first panelist. I ask that you hold your questions until the question and answer period that will begin after the last presentation. It gives me great pleasure to introduce our first speaker, Dr. C. Everett Koop, Surgeon General of the United States Public Health Service. Dr. Koop is a graduate of Dartmouth and the Cornell Medical College and a renowned pediatric surgeon, as well as one of the nation's most outspoken anti-smokers. During his tenure as Surgeon General, he has issued 4 important annual reports on the health consequences of smoking, and his forthcoming report on the consequences of involuntary smoking promises to rival the original 1964 report in its medical and public policy significance. Dr. Koop.
Thank you, John. I'm delighted to be here, ladies and gentlemen, and have a small part in the 350th anniversary of Harvard and the Kennedy School's 50th anniversary. It all sounds like such a long, long time ago, but Harvard has been here for only 7 generations, back to the time of your great-great-great-great-great-grandparents, and that's not so far back. Many of you probably know 1 or 2 people in your acquaintances who are great-grandparents, and these are men and women who have lived practically a century, and they had to be born in an age of Brahms and Tolstoy, Louis Pasteur and Robert Koch, and they might have heard stories by their own grandparents about the delights of Mozart and Goethe and the wonders of Lavoisier and Edward Jenner. But it's not so long ago. But a lot has happened in medicine and health across these generations, and we've learned a great many things that can help our own generation be a little bit healthier as we try to live just a little bit longer. And that's what this smoking problem is really all about. That's what my predecessors and I have been doing in telling people that science has come up with new and important information, something science has been doing since Aristotle, that proves the lethality of cigarette smoking. Over the past 30 years, almost a generation of biomedical researchers, physicians, and public health personnel from more than 80 countries have generated the hard evidence linking cigarette smoking to about 24 serious disease conditions. The world medical literature has an inventory of more than 50,000 studies on smoking and health. The overwhelming majority of these studies clearly implicate cigarette smoking either as a contributing cause or the primary cause of illness and death. For example, we know that a person who smokes has a risk of sudden cardiac death that is 3 times the risk of a non-smoker. We know that about 85% of all lung cancers in the United States are caused by cigarette smoking, and people who smoke a couple of packs a day have a lung cancer rate that is 25 times greater than the rate for non-smokers. We know that cigarette smoking is the major cause of chronic obstructive lung disease, especially emphysema and chronic bronchitis. In fact, emphysema is quite common among our older generation that smoke, but it's rarely found among older non-smokers. And doesn't that of itself tell you something? And we know that pregnant women have an increased risk of delivering their babies prematurely, of aborting the fetus spontaneously, or of delivering a stillborn child, or of giving birth to a child who simply won't have the ability to survive more than a few days outside the womb. Now, those are facts of a case that is scientifically conclusive. Smoking is the leading preventable cause of disease and death in this country. That verdict of science has been rendered ever since the first Surgeon General's report on smoking and health, released by one of my predecessors, 1964, then Surgeon General Luther L. Terry. By the time I assumed the position of Surgeon General in 1981, another dozen reports had been released by 3 more Surgeons General, Dr. Stewart, Steinfeld, and Richmond. By the time Dr. Julius Richmond left Washington and returned here to Harvard, the scientific case against cigarettes was airtight. Nevertheless, since 1981, we've produced 4 more reports, as Dr. Finney said. They documented the relationship between smoking and cancer, smoking and cardiovascular disease, smoking and chronic obstructive lung disease, and the most recent one on smoking as an additional occupational hazard. I might add that this process of research and public education has continued through 5 presidents, 2 Democrats and 3 Republicans, and through 10 sessions of the United States Congress. It has continued through lavish budgets and through tight budgets, and it's still going on, Graham, Rudman, Hollings notwithstanding. Now, the government's latest step has been to require cigarette manufacturers to put new and stronger warnings on their packages and on all their advertising. There are 4 versions, and they must be rotated every 3 months. There's nothing fancy, nor is there anything vague about these warnings. One categorically says smoking causes lung cancer, heart disease, emphysema, and may complicate pregnancy. Another is more specific and warns that pregnant women who smoke risk fetal injury and premature birth. A third makes it clear to everyone that cigarette smoke contains carbon monoxide. And the fourth warning says that quitting smoking now greatly reduces serious health risks. In other words, it's never too late to quit. It's not easy to do, since nicotine is the most addictive drug in our society, but it's never too late to do. Now, they aren't what you'd call wishy-washy messages. They're the blunt truth, and they're firmly implanted in federal law, Chapter 15, Section 1331 to be exact. That, in abbreviated form, is the case against cigarettes. But the information gathered so far mainly concerns the health of people who smoke. However, that's beginning to change, since we now know that behind every cloud of mainstream smoke is a cloud of side-stream smoke. Now, what do I mean by that? Smokers engage in mainstream smoking. That is, they inhale the smoke directly into their lungs from the cigarette and not from the ambient air around them. But the side-stream smoker involuntarily inhales the cigarette smoke that is in the ambient air. About 10 years ago, we began to perceive that this new aspect of the smoking issue was indeed important. We began to learn about the effects of cigarette smoke upon the health of non-smokers, the so-called side-stream smokers. For example, the children of parents who smoke have a much higher rate of colds and other respiratory infections compared to children of parents who do not smoke. We've also learned that the non-smoking wife of a smoker runs a higher risk of lung cancer than does the non-smoking wife of a non-smoker. Before long, we expect to have clear evidence that the same is also true of the incidence of heart disease, emphysema, and congestive lung disease against the non-smoking wives of smokers. And side-stream smokers exposed to other people's heavy smoking in the same enclosed workspace absorb as much as if they themselves were mainstream smoking 2 or 3 cigarettes a day. Now, just what is it in cigarette smoke that's so harmful for everybody, smoker and non-smoker alike? Well, for starters, both the side-stream smoker and the mainstream smoker breathe the same 4,000 or so constituents of cigarette smoke. They both inhale the same tars, the same naphthalene, the same pyrene, the same benzopyrene. They absorb the same carbon monoxide, methane, ammonia, acetylene, and hydrogen cyanide. Oddly enough, scientists have discovered that some of these toxic agents are found in greater concentrations in the side-stream smoke than in the mainstream smoke. Tar, for example, the substance that is the most carcinogenic, is 70% more concentrated in side-stream than in mainstream smoke. Carbon monoxide is 2.5 times more concentrated. Nicotine, 2.7 times more concentrated, and ammonia, 73 times more concentrated, and so on. Now, this ought to be alarming for the 2/3 of the American population who think they do not now smoke. They really do. They may have saved themselves from the stink and the mess of smoking, but they have not completely protected themselves from all of the health hazards of smoking, and those hazards are in that same ambient air we non-smokers share with smokers. It's that kind of information that has become the foundation of the movement by non-smokers to ban smoking in virtually every public space and in all public transport all across these United States. And I am pleased to report in a number of other countries as well. It's a tremendous grassroots campaign, and it's directed against one of the most powerful members of the American economy. You're aware, I'm sure, of the economic power of the cigarette industry. It accounts for 2.5% of the nation's gross national product, or $60 billion annually. It spends over $2 billion a year just on advertising. That's $8 for every person in the United States, smoker and non-smoker alike. And despite the billions of dollars that it's spending, I still believe that the days of the cigarette industry are numbered. History is on the side of the non-smoker. The cigarette industry, as we know it, for all its economic power, which is enormous, will disappear over the next 20 years, and we will become a smoke-free society, which is a goal I set for this country 2 years ago. For example, I believe that the anti-smoking attitude in this country will become so forceful that well before the turn of the century, the smoker will not smoke in the presence of the non-smoker without asking for and obtaining his permission. We're already seeing the decline of the per capita consumption of cigarettes. down to the lowest levels now since 1944, a trend that certainly will continue. And despite mergers and buyouts involving food companies, the cigarette industry is not and never will again be a growth industry. I sincerely hope that the men and women who run the cigarette companies are doing their homework. I hope they're beginning to think the unthinkable. That is, I hope they're preparing themselves for the kind of role that they also can play in a country that is smoke-free. I can assure them, and I want to assure the American people as well, that the Public Health Service and its Surgeon General will do whatever we can, consistent with our commitment and with the law, to help those industry leaders become the kind of employers and the kind of citizens who thrive in a business that enhances life and not the kind that invites death. So I think the American people are winning the battle against smoking, the single most significant and most preventable cause of death in our society. Our motivation is to protect and strengthen the public health, and our weapons in this battle are biomedical science, public education, and the law. Thank you.
Thank you, Dr. Fisher. Our next panelist is Dr. Tenley Albright, a practicing surgeon and an officer of the Advanced Medical Research Foundation. Dr. Albright is a graduate of Radcliffe and the Harvard Medical School and holds an impressive number of honorary degrees and professional appointments. Since winning the Olympic gold medal in figure skating in 1956, Dr. Albright has remained active in amateur athletics and has served in various capacities with the United States Olympic Committee. In her clinical work, Dr. Albright is an innovator and an advocate of exercise programs for the elderly and a staunch advocate of the responsibility of the medical profession for eliminating smoking. Dr. Albright.
Thank you. I appreciate being here with all of you. And I must say, after hearing our Surgeon General, I'm all the more glad that I didn't come here to motivate myself to stop smoking. One thing that keeps coming up in our discussions is how tough that is. And as I look out here among you, I'm sure there must be former smokers right here in this room. And I just want to say that it must have been tough, but how wonderful what you've done for yourselves, and congratulations. As we celebrate this 350th and the 50th of the Kennedy School, the second anniversary of the Institute, and look forward to the year 2000, we're also well aware that we have over 50 years of history about smoking and knowledge about smoking behind us. And proof that we do need to be here talking about policy and what we can do is that terrible number, that 350,000 people who died this year prematurely from cigarette smoking-related illnesses. Our attention to smoking, of course, is important in itself. To me, it has a special added importance, and that is it's an example of what can be done and how it can be done in preventive medicine, in prevention of illness, in trying to keep from getting sick in the first place. Every time I'm in the operating room, I can't help wondering what it was that made us have to be there. What the critical thing was that created a situation where the patient had to be under general anesthesia, had to have major surgery, had to face the discomfort of convalescence. Makes me stop and wonder what is preventable and what can we do. And of course, as the Surgeon General said, smoking is the single biggest risk factor in illness. It's the single biggest cause of cancer and cancer mortality in this whole country. The big important word here is it is preventable. And what started as anecdotal reports years ago about the effects of smoking on the body became consistently repetitive so that they had to be noted and had to be paid attention to. And now with all the epidemiological studies and reports and the research, we have over 45,000 articles, and you update me and say 50,000 articles published on this one subject. And even with the 64 pages of computer printouts, hundreds of feet of computer readouts on the subject, there are a lot of us who've had our own reasons for being hard on patients and seeming rather mean to them. Dr. Richard Overholt, who's a famous thoracic surgeon here in Boston, has followed this whole area from when he first started doing thoracoplasties, an operation which was to rest a tuberculous lung to allow it to heal. That was 50 years ago here at the Norfolk County Hospital. This was a new procedure. He had tremendous success, such success that other county hospitals begged him to come there and do the operation there too. He started to. To his chagrin, his results were not as good. He had some mortality. And in looking at what happened, the Norfolk County General Hospital, even 50 years ago, had a no-smoking policy. The other county hospitals did not, and that was the difference. He began to refuse to operate, even in those days, on people who smoked, and he found that the people who were willing to stop smoking 3 weeks prior to surgery had better results, and not the mortality rate that the smokers had had. Following that, he did the first right pneumonectomy, which was removing a part of the lung. Before that time, surgeons didn't look at the lung tissue itself, that beautiful pink spongy tissue. When he did open into the chest and looked at the lung and watched it expanding and contracting, much to his horror, he saw that the lung in smokers was black, not the healthy pink. At that time, he spoke of his alarm and he communicated his concern to medical societies, to fellow physicians. And think of the time that it's taken for us to look at that and realize how true that was, and what was known 50 years ago is still considered pioneering now. Dr. Overholt continues to be a pioneer to this day and has followed this movement every inch of the way. I've come to expect a patient the night after surgery to have fever. I just assume if he's a smoker he has fever, otherwise I don't expect it. That constant irritation, the chemical irritation and inflammation that smoking causes on the delicate lining of all the tiny bronchioles and the alveoli, the inflammation, the healing, the inflammation, the healing, the scarring, denudes the delicate lining and strips the little tiny hairs, the cilia, from the lining. Now those cilia normally keep the particles out of the lungs. So the lungs' resistance becomes lowered and secretions pool in the lungs following surgery. Also, the alveoli become less elastic and air is trapped in them. So what the patient ends up with from the chronic smoking is really inefficient bellows. Instead of expanding and contracting, the lungs work ineffectively this way. Each person here undoubtedly can cite a personal experience with someone close to him who's been through suffering from smoking. But I do think it's good to focus on our own experiences because it brings it home. It makes us realize it is an immediate problem and how close it can happen. I've also had painful experience of watching helplessly. I'll never get out of my mind the picture of a 50-year-old woman, Evelyn, who was a chronic smoker, used to her cough, always having cigarette smoke emanating, or the odor emanating from her clothes. And every time she came for an examination, I would voice my concerns, go over things with her, try everything I could to try to encourage her to stop smoking. But she'd say, I can't. I really don't want to. But she did come back for examinations, and I'd brace myself, walk in the room, try again to think of some new way to encourage her and convince her. And one day when I went into the room and I took her hand to take her pulse, it was my pulse that went up, because as I looked at her hand, I noticed that she had beginning clubbing of the fingers, pulmonary osteoarthropathy. That's a deformity, a bulbous deformity of the ends of the fingers that can be a sign of lung cancer. We got another x-ray this time too, and sure enough, she had developed lung cancer. And I can tell you it was a very painful experience. It hurt not to have been able to prevent this. And it was very difficult emotionally following her during the next less than a year that she lived. We talk about lung cancer, but I do think we should take a moment, as the Surgeon General has mentioned, about all the other things that that smoking is a risk factor for, things other than lung cancer. Of course, there's heart disease. There's an increased number of heart attacks and an increased number of sudden deaths from heart disease. There are strokes, an increased incidence of strokes, and peripheral vascular disease. The small blood vessels of the extremities, particularly the feet, become affected by arteriosclerosis and go into spasm much more frequently. In fact, smoking can defeat an operation that's been done to restore blood supply to the lower extremities and the feet. Cancer of the bladder is increased in smokers. 40 to 60% of cancer of the bladder is thought to be due to smoking. In the GI tract, there's an increased incidence of ulcers, peptic ulcers. And of course, there's the cancer of voice box, the larynx and the pharynx, increased by smoking. Cancer of the esophagus, which is particularly increased when it's a combination of cigarettes and alcohol. Then there are the complications of oral contraceptives. Those are markedly increased in smokers, so much so that I don't give oral contraceptives to women who smoke. When the birth control studies were first done with the concerns about complications, the groups were not divided into smokers and non-smokers. But when they were, it was noticed that the women who smoked had a much higher incidence in thromboembolic disease, that's clots. They had a 10 times greater incidence of deaths from heart disease. They had more subarachnoid hemorrhages, bleeding in the brain, and strokes. Smoking has even been implicated in increasing wrinkles. Of course, it is the biggest single risk factor in the obstructive pulmonary disease, bronchitis, and emphysema. And one other important area is maternal smoking. We've already heard about that, and that's something that Professor Schelling has some very important ideas about helping and working with the obstetricians on, because of the fact that women who smoke during pregnancy cause a retardation in the development of the fetus. And babies have a lower birth weight. There's more spontaneous abortion. There's more death in the uterus and more death just after birth as well. But there's also a 50% increase in some cancers in the offspring of women who smoke. Well, to think that stopping one thing or changing one specific variable can affect every system of our body is quite impressive, and it sounds great. But here again, the very fact that almost 10% of physicians still smoke shows how difficult it is to stop smoking. When we puzzle about ways to change this and what can be done about it, there are about 8 different categories we can look at. And just to go through them very quickly, we can go over them more in the discussion period. One we've talked a lot about today is knowledge. We know that helps. Look what has happened so far. We know it's not enough. The same with education at all levels, education with physicians, also of grade school children. But it's very difficult to tell a teenager you shouldn't smoke because every cigarette you take will shorten your life by 5 minutes and a quarter. The teenager will probably say, well, who wants to live to be that old or over 50 anyhow? There have been attempts at effecting a change by decreasing tar and nicotine. That has its problems too. There are the financial incentives, which are important to try to encourage people not to start smoking. And those, of course, are increasing the price of cigarettes and increasing the excise tax. Then an important area is the insurance benefits. The premium decreases for people who don't smoke, and the insurance penalties. The increases in fire insurance for people who do smoke. And de-glamorizing, that's important. It's known that the single most important factor in getting youngsters to start smoking is the peer pressure. It's interesting to note that nobody likes a cigarette the first time. The first drag is never a pleasant one. People have to teach themselves to the habit, really. And then, of course, there are regulations, and what a lot of progress is made in that area. The importance of regulations is an example to show that people do believe it is so important. And I was pleased to see that Dean Marty Feinberg at the Harvard School of Public Health has this year instituted a no-smoking policy. As we consider all these things, it is important for us to remember that 90% of smokers do want to stop smoking. Very important for us to support them and encourage them when they indicate they do want to stop. And as we coordinate our efforts, I hope we'll be encouraging each other to keep up the momentum, and certainly by working all together we can make the difference. Thank you.
Thank you, Dr. Albright. Our third speaker is Dr. J. Jarrett Clinton, Deputy Assistant Secretary of Defense for Professional Affairs and Quality Assurance in the Office of the Assistant Secretary of Defense for Health Affairs. Dr. Clinton received his MD from Kansas University and his Master's in Public Health from Johns Hopkins. He's also a graduate of the Senior Fellows Program here at the Kennedy School. Dr. Clinton has had a distinguished career in international health and with the U.S. Public Health Service. And in his position with the Department of Defense, he's been one of the principal architects of the Department's health promotion policies, and he has been an extremely strong advocate of smoking control policies for the military. Dr. Clinton.
Thank you, John. It's indeed a great pleasure to be here, to be a part of this celebration, and to represent the Department of Defense in what is not a traditional Department of Defense activity, namely to come to grips with some very significant public health issues, this one being smoking. For decades, smoking has been a part of military life. The average 18-year-old joined the military and learned quickly to smoke, to drink, and to perform the way his senior enlisted officers did. Cigarettes were in C rations, smoking breaks were formalized, giving some institutional endorsement, indeed acceptance of these practices. Things did change. In 1977, cigarettes were taken out of C rations. They're not called C rations anymore. It's a side point. And in 1977 also, the department issued regulations that prohibit smoking in specified areas of buildings. But not much more than that was actually accomplished during that time frame. It was only recently that we began to come to grips with the issue. Let me step aside for a moment and talk about some of the numbers. In 1980 and 1982 and 1985, the Department of Defense has conducted a worldwide survey of drug and alcohol abuse. This is done with a sample size of approximately 20,000 worldwide and focused predominantly on the issue of drug abuse and alcohol, which we were greatly concerned with. In each of the three surveys, however, we've had some smoking questions. The questions in our 85 survey were far more specific. There are enough changes in the question over time that it's difficult to make accurate comparisons among the three surveys. The primary question in our 1985 survey was, how many cigarettes did you smoke in the past 30 days? That time frame being the same time frame in which we asked questions with regard to drugs and alcohol. The overall prevalence of smoking in 1980 was 52%, and a similar rate in the 1982 survey. In 1985, results that were released this spring, the overall rate was 46%. 31% of our 2 million people in uniform smoke a pack a day or more. 1 in 4 smoke a pipe or cigar. 1 in 5 use smokeless tobacco, but I would note on a very infrequent basis. Now, as you think about those numbers and compare them with other sets of numbers you hear, keep in mind that the military is basically a very young population group. And most of the enlisted personnel are employed in a job that's much more related to a blue-collar job than it is to any other white-collar professional group. In the 1985 survey, the highest prevalence rates for smoking were among enlisted personnel, with higher-grade enlisted personnel having rates of 55%, compared with warrant officers of around 40% and commissioned officers of around 20%. Heavy smoking then was concentrated in the senior enlisted groups, but particularly the E7s and E9s. The pack year accumulation of cigarettes over time was highest in that same group, and those that had been in the service more than 10 years, those over the age of 30, those married but not living with their spouse because of the circumstances of their assignment, and those with less than a high school education. Now, while there had been a committed few who were concerned about issues of health promotion as normally defined in the department since the 80s, as the Surgeon General's office was looking at a number of issues, health promotion, disease prevention, the publication of healthy people, similar efforts were going on within the department, but not in consort with the Department of Health and Human Services at that time. There had been growing efforts then by this committed few to look at issues of health promotion in the broadest sense and to deal with the issue of smoking, which indeed, by everything we knew, was of significant proportion. Whether or not it's comparable to America or not remains to be seen at that point. Our discussion had not gone unnoticed in this case, and the Congress became aware that much more could have been done and required that we put together a panel of public health experts to assess what we're doing in health promotion and specifically looking at issues such as smoking and make recommendations to the department. We brought experts together from the Public Health Service, from the Centers for Disease Control, from the Office of the Secretary and HHS, from academic institutions including John Penning from Harvard, and others to review what we were doing in the health promotion areas and make those recommendations. Panel members concluded that much had been accomplished in areas such as physical fitness and weight control and nutrition, things in which the military experience is really most noteworthy. And indeed, our experience in drug abuse prevention was also extraordinarily noteworthy. But things such as alcohol abuse maintained the same rates, smoking was very high and alarming rates, and other issues deserved attention. They argued then that we needed a well-organized, well-integrated, aggressive program in health promotion, using the term as generally defined by the Department of Health and Human Services. In response to that report, which went to the Congress, we developed a health promotion directive policy intended to support and influence individuals to change their lifestyles and take responsibility through self-care for a number of these issues. Our health promotion policy at this point incorporates the following areas. First, the triad of physical fitness, weight control, and nutrition. The second triad of substance abuse, drug abuse, alcohol abuse, nicotine abuse, smoking. And finally, stress management and the early identification of hypertension, the latter not normally being included in health promotion programs, but for a variety of reasons, is included in ours. As we developed this directive and began the discussion that occurs in the Pentagon when these things are developed, indeed throughout the services, not just the building the Pentagon, one of the key issues of debate was the provision regarding the sale of tobacco products in military commissaries, the exchanges, and on ships. The basic options of raising tobacco prices, of removing tobacco from commissaries, or continuing the status quo were indeed examined. And faced with the differences of opinion among a wide circle of folks, it was clear that we needed a much more thorough review of the economics of the pricing of cigarettes and the sale of cigarettes in the military. Almost at exactly the same time, the Congress became aware of this debate and indeed required that we submit to the Congress a formal report examining these various issues. We were to look at the consequences of smoking in military personnel, the cost to the medical health system, the economic impact on our exchanges and commissaries, and what would happen if we did indeed change those prices. The report, prepared by a broad representation of the Office of the Secretary of Defense, summarized the smoking prevalence data that I have just presented to you, concluding that smoking rates between enlisted personnel and the near equivalent blue-collar population of America were not greatly dissimilar. One could argue that point for a long time. And acknowledged also that the economic consequences of smoking in the DoD medical system were approximately in the order of $200 million per year, and estimated that changes in tobacco prices to reflect private sector prices might result in an 8 to 10% reduction in consumption of tobacco products by service personnel. 8 to 10% reduction. Let me say it as a side, something about the price of cigarettes in the military. They are on the whole about 35% less expensive in our commissaries, which sell foodstuffs predominantly, than they would be in the average private sector store. In the exchanges, which predominantly sells clothing, and that articles like those, the price differential will be something like 20% less. A good deal of cigarettes are indeed sold through these exchange and commissary systems. In FY85, as I recall the number, it was approximately 1 billion packs of cigarettes sold through the system. Now, while the increase in tobacco costs would not be a significant increase to the average individual military member, the increase in cost would be something in the order of maybe $80 to $100, maybe $130 annually for each smoker. The military member, it was thought by many, might perceive a greater loss of benefits and a loss of freedom of choice. That debate continued for a long time. The result, according to many, would have a near-term impact on the morale of our forces and on the retention rates, which is an important part of the structure of the military today. Keep in mind that we recruit approximately 300,000 new members to the armed services each year out of a total pool of about 2.1. So in any given year, about 1/7 are coming in. Retention of those people in which a good deal of financing has been developed for their training and support is a significant issue. Following review of all the alternatives available to the Secretary, he concluded that buying products in commissaries and exchanges was indeed an old, established, and valued part of the total compensation package available to military members, and decided at that point in time not to change the pricing of cigarettes, but rather, in an extraordinary memorandum to the services, directed an intense campaign directed at all levels of command and to all the services for an anti-smoking campaign. Following the resolution of this pricing issue, the directive was issued, and in the spring of this year, the services began the development of specific regulations to put in place various things noted in the Health Promotion Directive. With regard to smoking, all three services have at least the following items. Smoking prevention and cessation as a philosophical approach is aimed at creating a social environment that supports abstinence from tobacco use and discourages the use of tobacco products. Permission to smoke in DoD, Armed Services buildings, is allowed only to the extent that it does not endanger life or property, and there's no risk of impairing non-smokers' health. The Army regulation further states that smoking is prohibited in all Department of Army facilities unless specifically allowed. They note, however, that some smoking areas will be necessary to avoid undue inconvenience to persons who do desire to smoke. There is prohibition of smoking in auditoriums, conference rooms, classrooms, restrooms, gyms, fitness centers, family service centers, and a variety of facilities that you would expect. There is prohibition of smoking in all Army vehicles, in all of the Navy and Air Force vans and buses and other multi-passenger vehicles. Smoking is disallowed in all Army aircraft, although it is allowed in some Navy and Air Force aircraft. Eating areas must all have smoking areas and non-smoking areas designated. Smoking areas only if there's adequate ventilation, and to some extent that's been defined. Healthcare professionals are not allowed to smoke in the presence of patients and are directed to raise smoking issues with their patients whenever appropriate, and particularly for high-risk patients such as pregnant women. The services are obligated to provide smoking cessation programs to all those who say they want to quit. The services are now in the early implementation process of this program. As I indicated, the regulations making these specifications came out in basically spring to summer of this year. We have indeed attracted the attention of a great number of institutions. Many of them have been exceedingly helpful. The American Cancer Society, the Heart Association, the American Lung Association, the National Institutes of Health have provided great expertise in the information, education, motivation area. We have received many materials free. We've been given masters of documents that we can use from the Public Health Service and many other agencies free that we can reproduce and move to our people throughout the world. We have created and borrowed and adapted messages from all these media to use in our own Armed Forces radio and television network, which is rarely available in the United States except in areas such as San Antonio, but is widely available to our forces outside the United States. We have then, I think, taken some responsibility as a federal agency to examine one of America's major health problems. We have had what I would consider a fair and very vigorous debate within the Department of Defense. Issues of the compensation packages to military members we reviewed carefully. We looked at the data. We recognized the impact on the commissary and exchange system and the money that creates for things such as recreational equipment in the long run. It was a difficult decision indeed for the Secretary of Defense. I believe, however, his earnestness and his commitment to an anti-smoking campaign has been heard very clearly by the services, and I think the evidence to date indicates that they're very serious in moving along with this anti-smoking campaign. Secretary Weinberger's memorandum is very clear in that he will assess the progress made without a specification of time, but I would think 2 years is a reasonable time, to judge whether that alone is sufficient to reduce our smoking rates. I'm not sure what lessons we have for other federal agencies or indeed for America in general, but we think we have engaged a serious problem and believe it will contribute to the health of the 2 million people who are in uniform today. Thank you.
Thank you, Dr. Clinton. Our last panel member is my colleague, Thomas C. Schelling. Tom is the Lucius N. Littauer Professor of Political Economy in the Kennedy School and Director of the Institute for the Study of Smoking Behavior and Policy. A distinguished political economist, Tom is a graduate of the University of California at Berkeley and received his doctorate in economics from Harvard. He served as a consultant and advisor to numerous government agencies, including the Departments of Defense and State and the Arms Control and Disarmament Agency. In addition to his interest in arms control, he has been deeply involved in issues as varied as organized crime, the energy crisis, and substance abuse. He was a member of the Committee on Substance Abuse and Habitual Behavior of the Institute of Medicine, and this experience, combined with an intense interest in issues of self-control, led Tom to dedicate a significant portion of his considerable energy to smoking and the creation of the Institute. Tom Schelling.
We heard such frightening and properly frightening things from Drs. Koop and Albright that I want to spend a little time emphasizing the good news. One of the most stunning social trends in this country since World War II is the decline in the prevalence of smoking, and more recently the decline in the status of smoking as a social activity. 20 years ago, more than half of all the adult males in this country smoked. The number is now a little less than 1/3. 20 years ago, 34% of all women smoked. The number is now down to 28%. Women lagged behind men in taking up smoking. They were still on a strong rising trend when the overall decline set in. It is not surprising that the decline among women has been less than among men. There are now nearly as many former smokers in this country as there are smokers. Quitting is one way that the numbers have come down. The other way is that not nearly so many people are taking up smoking. My generation, the people who were born in the 1920s, had their peak smoking period in the late 40s and the early 50s. 70% of us smoked. The figure today for people in their 20s is exactly half that. And even among women who reached their peak smoking levels in the 1960s, 10 years later than the men, it was still my generation because women peaked in their smoking at a later age. The figure is down from 45% to 35%. So it is perfectly clear, just on demographic grounds, if the initiation of smoking stays even where it is among young men and women, there's going to be a lot less smoking as these people grow up and fill out the other age groups in the population. And since males have been taking up smoking at a rate that is declining
almost 2% per year, I think it is fair to conclude that there's a good likelihood that smoking will have disappeared along about the time we hold our centennial here at the Kennedy School. Even in high school, seniors who smoke regularly are only 2/3 of the numbers of 1 decade ago. Now, the qualification to this is that although people in lower socioeconomic status than you and I are quitting, they originally smoked more than we did, and they're not quitting as fast. The people among whom smoking has almost disappeared are the socioeconomic group that I described as the people who wear neckties to work. Educated middle and upper middle class males. Educated middle and upper class females are lagging behind them. But let me just read you a few numbers that suggest the correlation of smoking with economic status. Among males, professional and technical people have a smoking prevalence of 26%. Other white collar is up from 26 to 38%. Blue collar are up from 38% to 47%, and the unemployed are up from 47 to 54%. That's a very striking indication that smoking in this country by the end of the century is likely to be a lower class, working class, and unemployed activity. And people like us who are already probably in better health and have access to better medical care will be the people primarily relieved of this one particular scourge. The figures for women are similar, though not as striking, the correlation between economic status and smoking. Among high school seniors, those who are not bound for college have 2.5 times the smoking prevalence of those who are bound for college. And I remind you that Dr. Clinton pointed out that in the military services, non-commissioned officers have a prevalence rate higher than 50% and commissioned officers below 25%. Now, some more good news, but again, it's quantified good news. Nearly everybody who smokes, according to polls, that is over 95%, know, or at least answer yes to the question, can smoking cause lung cancer? They answer yes to the question, can smoking cause heart disease? Yes to the question, does smoking cause emphysema? Or maybe the questions in each case were, is it a leading cause of? They know it. Why don't they quit? Well, here the evidence is interesting. 2/3 of all the smokers in this country claim to have made at least one serious attempt to quit. A very striking figure. Among the very youngest age group for which we have good survey data, 21 to 24 years old, among both the men and the women, more than half made an unsuccessful attempt to quit within the past 12 months. They no sooner get hooked than they know they shouldn't quit, and they do something about it, and most of them do it unsuccessfully. Among those who have quit in this country, 2/3 of them failed on the first 2 or 3 tries. That leads me to suggest that if any of you came here to find out how to help somebody quit smoking, the best advice to give is, if you try and fail, try again. If you try and fail, you're like everybody else. And the people who ultimately succeed are the ones who keep trying. God doesn't deny you an unlimited number of times to keep trying to quit. The other thing that's, I think, striking about smoking in this country is this decline in the status of smoking. The Surgeon General pointed out that it will soon be the case, and among our people it already is the case, that smokers are reluctant to light up in the presence of non-smokers and frequently ask, or frequently would rather not even ask, but just do without smoking. The status of smoking, a good indicator of it is that you almost never see anybody smoke on television anymore, except in the old Bogart movies. It used to be the case that when you tuned in Channel 2 in Boston and saw somebody like me discussing international affairs, you could see us through graceful columns of smoke that were rising in front of the camera. Ashtrays were always made available, and the television people knew that people like me were much more poised in front of the camera if I were smoking, and smoking was not only allowed, it was encouraged. Now, newscasters never smoke. There was a study recently of the incidence, that is, of the frequency of smoking incidents in TV drama and situation comedies. Several hundreds of hours of drama and sitcoms were looked at by people who coded the number of smoking events. A smoking event would be lighting a cigarette, appearing with a lighted cigarette, putting out a cigarette, fondling cigarettes, or something of the sort. They did this for 4 periods. The first was the 3 years just prior to the first famous Surgeon General's report, the early 1960s. The last period they did it for was the early 1980s. The frequency of smoking incidents on TV drama and situation comedies was down tenfold. That is to say, it was barely 1/10 as much a few years ago as it had been 20 years before that. I'm not sure why. I think it's partly that the people who act on television probably are most of them former smokers who don't want to smoke again, even for the sake of the camera. Probably a lot of it is that TV advertising of cigarettes disappeared in 1972, and there is no threatened advertising revenue loss to TV channels. I think it's also the case that the television producers hear from a lot of the people responsible for children's smoking, and they're very sensitive. Whatever the reason, for a lot of people who spend a lot of time in front of television, they are no longer as aware of the smoking going on around them in that medium, just as they're aware of much less smoking going on around them in rooms like this, in aircraft, in hotel lobbies, in conference rooms, in restaurants, and everywhere else. And inasmuch as smoking is essentially a communicable disease that people learn from each other and have it reinforced by the smoking of others, I think this decline in the status of smoking and the decline in the frequency of smoking is bound to have a multiplier effect. Dr. Albright complimented Dr. Dean Feinberg on having put into effect, I believe last Monday was it, a very severe restriction on smoking in Harvard's School of Public Health. Harvard, you know, is not a university, or rather it is a university. It's a bunch of independent schools. And if anything is going to happen, it's going to happen piece by piece. And the first school at Harvard to take strict steps to help provide a healthier atmosphere for the workforce was not improbably the School of Public Health. But I will predict that if you return next year, don't wait 50 years, return next year in September, I predict that very, very serious regulations on smoking will have been put into effect by the John F. Kennedy School of Government, by the City of Cambridge, and by the state of Massachusetts. And I think this progress, though it takes decades, not years, deserves to make us feel a little better than if we had been forced to keep on looking at those black lung linings that were held up to us a few minutes ago. Thank you.
We now begin a question and answer period, and I am compelled to lay down some ground rules. First of all, we'd like you to stand at one of these two microphones, here or over there, to ask your question, and if there are more than one of you to line up. Secondly, we'd like you to limit your question to 1 minute and to make it a question, not a personal statement of philosophy or opinion, but to make it a question. And third, to address your question to a specific panel member. And so now I invite you all to ask your questions.
I'd like to address my question to Surgeon General. We've heard that nicotine is a powerfully addictive drug, and we've heard that 90% of smokers begin smoking when they're children.
That Congress ever discussed and decided was not a food, not a drug, not a cosmetic, and therefore could not be regulated. So that with this tremendous history of preferential treatment of tobacco, with the ability of those tobacco-growing states to lobby successfully with their colleagues in Congress, I don't think we can ever declare nicotine to be a drug that is not going to be a legal product in this country. It's sad, but it's true. Question here.
This is for Mr. Clinton. I'd like to know, please, what, if any, are financial incentives available for entering military personnel? For example, giving them a higher salary if they don't smoke, or incentivizing them financially. Is it useful?
That's not been considered. Whether it would be useful, that's another question. I think that the compensation package is so complex, it would be unlikely, I think, that the department would give preferential treatment to a specific group for anything. I think it's unlikely that that would occur.
But even if it works, I mean, it's proven to work. And you get $500 a year extra cash if they don't smoke cigarettes.
It's a noteworthy suggestion, and I'll carry it back.
Sure. You mentioned a probably smoke-free school, Kennedy School of Government. What's the future for smoke-free flights? And second part of the question, can the smoke in the air in an airplane will be purified?
I'm going to guess that the next Surgeon General's report, which we've been told will be on the subject of involuntary smoking, will reflect in its scientific articles something like what he told us, namely that cigarette smoke is a significant health hazard to non-smokers. There's a recent National Academy of Sciences committee report on the subject of air quality in passenger aircraft. I don't think it was originally intended to focus on cigarette smoke, but on a number of other things, ozone, carbon monoxide, and the transmission of disease in the air. But I think I haven't seen the report. I think one of the strongest parts of the report, surely what has been taken up, was leaked to the newspapers and made the headlines, is the extraordinary extent to which, as in this building, smoking in one part of the airplane leads to smoke showing up in other parts of the airplane because of the inadequacy of the ventilation system. And ever since the energy crisis, the aircraft have been using their air exhaust systems at about 1/3 of what they were developed for in order to save the cost of pumping and heating the outside air. But I have a hunch that the pressure will build up so much after this next Surgeon General's report comes out that the Department of Transportation will have to look very seriously at the National Academy of Sciences report and consider eliminating smoking on aircraft, at least on short flights, and by short flights I would mean a couple of hours. It may, on longer flights, demand that the aircraft improve their ventilation systems. That's expensive, but it may put the airlines in the position of having to choose between very expensive retrofitting of their ventilation systems for telling people who want to fly nonstop from Seattle to Boston to make a stop in Chicago and get off and smoke before they get back on again. My own observation, I fly a lot between here and Washington, is that hardly anybody on the flights I take, which tend to be commuter time flights, hardly anybody smokes, because for an hour's flight, most smokers would rather sit up front and get to the taxi 5 minutes earlier than to have to sit in the rear, especially since the unintended but fascinating consequence of congregating all the smokers in the rear of the airplane is that the smokers find the air back there so foul that they often sit up front. And the reason why now the announcement is you may not smoke in the aisles is that smokers were sitting up front and walking to the rear to smoke, standing up in the aisles and walking back up front to get rid of their own smoke. I think the future of smoking on airlines is pretty dim.
I hope to put the final nail in that coffin. I've been concerned ever since I've been in this job about the health of airline attendants. look back on your next big flight to the rear of the plane and look at the blue haze in which those young ladies and young men have to work. And I can't tell you what airline or what sex we're working with, but I have a bunch of people now who are sending urine samples to a laboratory, and I think we're going to prove in about 6 months that airline flight attendants smoke 3 to 10 cigarettes every flight.
This is for Dr. Koop, and I'll preface my question by saying that John Penny did call me up yesterday, and he did want to keep the debate and discussion lively. So if you're concerned with the question, you can look back at John. You stated, Dr. Koop, that the Surgeon General's report played an important role for establishing scientific fact and then also setting an agenda on public policy debate to reduce prevalence of tobacco use. An issue that's emerging today is the influence of tobacco promotion and advertising on getting young people to take up the habit and to continue, and other people who smoke to continue. Would you consider doing a report, a Surgeon General's report on the health effects of tobacco advertising and promotion?
I may do that. I have until November 1989 before I have to leave this job. And I must tell you that I have another job you probably don't know about, and that is that I am the chairman of an interagency committee on smoking and health that was mandated by Congress in 1984, and I already have had one meeting on just that subject. And the report of the very devastating effect of promotion and advertising on getting young people to start smoking is available from my office.
And for Dr. Koop, I'm Ed Sweeter, State House lobbyist for GAS, Group Against Smoking Pollution. First of all, I want to thank you for appearing earlier today at Cambridge City Hall at the announcement of the ordinance to restrict smoking in the workplace in Cambridge. My question to you, Dr. Koop, is to what extent can you or any other member of the government or even members of the public help to persuade the medical community to become more actively involved in political matters, not just those that affect their pocketbook, which they are very effective at influencing, but also trying to lobby for public health measures that don't immediately affect their own income, but will indeed improve the public health?
Well, I think that there are some encouraging signs, and I would like to take this opportunity to tip my hat to the medical students and the young medical and surgical residents in this country that I think have been responsible for pushing the American Medical Association into its present strong stand against smoking, and even coming out and saying that they would support a total ban on cigarette advertising. Because of the activity of the AMA, it filters down through organized medicine, even though the AMA doesn't quite represent 50% of doctors in this country. But I think that they are on the right track. One of the things that leads me to believe that is that we have in the Public Health Service a little syllabus and a series of slides that makes any physician into an after-dinner speaker on the hazards of smoking. And we've had a tremendous number of requests for that packet by physicians, which means that they have taken the message to heart and are willing to take it out and share it with other people. So I think that it is moving in that direction. One other thing that I think is important to note, and that is the change in the tone of the Journal of the American Medical Association. It used to be a rather pedantic kind of a journal that talked about clinical subjects and a lot of politics. Now I think it is one of the outstanding places where you can find messages on the prevention of the disease and the promotion of health. And I think that's another reflection of the attitude of organized medicine in this regard. Question here.
Yes, my question is also directed to the Surgeon General. You recently participated in some very vocal debate in Congress concerning a possible ban, wholesale ban on tobacco advertising. And you did generalize in your earlier comments that perhaps some of the senior management of the larger tobacco companies do see the writing on the wall. Do you see the resistance to measures such as what is proposed in Congress as a possible amendment to what you generalized about? Do you think that they really are willing to begin to back out of what is a very lucrative industry for them still?
Well, I don't think I quite said that. I expressed it as a hope that they would do this. The thing that disturbs me about this whole business is that for years, the cigarette manufacturers have been diversifying. And they have been buying up companies such as Nabisco and General Foods. I would suspect that no one in this room could live in his or her own community for 2 weeks and not support the tobacco industry, even though he never went near a tobacco product. They own the major department stores, they own toy stores, they own everything under the sun. They are diversified so that if they lost tobacco tomorrow, they would stagger for a week or two and then it would be all over and they'd be right on their merry way. Now, to do that at the same time that they carry out a tremendous campaign against me and my predecessors because we seem to have no love and compassion for the tobacco farmer seems to me to be the height of hypocrisy. Because if they were indeed concerned about the tobacco farmer, they would be buying their tobacco from him, but they're buying 30% of their tobacco overseas because it's cheaper. But one thing you ought to know is that because, as I said a moment ago, you can't regulate tobacco in this country, it's coming into this country loaded with deadly pesticides, which, if they were found on watermelon leaves in California, would take watermelons off the market.
Yes, my question is for Dr. Albright, but I'd also be interested in Dr. Coops and Dr. Schelling's reaction to this. Some people whose lives, you talked about somebody who you know whose life was affected adversely by smoking, and some people who have suffered lung damage and that sort of thing are trying to recoup their damages, recoup their losses through the courts. And I was wondering if you had to testify in a case like this, what would be your reaction, given that these people feel as though their freedom of choice has been taken away through their addiction to smoking?
Well, I guess the best thing would be if the courts could give them back their normal lungs. That I see as a tough question. I think, as I pointed out, nobody likes the first drag on a cigarette. People have to sort of force themselves to smoke to begin with. It's not always just the tobacco company. You could say indirectly it is because perhaps our peers who encourage us to smoke were encouraged by tobacco companies. I find it awfully hard to put the blame any place. I think that it's very important for us to realize that tobacco is perhaps unique in the fact that it is health damaging and dangerous when it is used specifically for what it's intended to be used for. That's where I think the problem is. And Mr. Zdarsky, who's an attorney for the AMA, has been involved in a number of testimonies on this situation. I think a lot of us have been surprised that so far the tobacco companies have not lost on this. I'd be interested in hearing from the other panel members who may have had experience giving testimony.
I'm not allowed to give testimony. I'd love to. I'd like to speak a little tangentially to this about another hypocritical aspect of this whole business. The tobacco industry says that we have never proven our case and that the jury is still out. That's not true. The jury has come back and they've said guilty as charged, and more so. But they hide behind the fact that you shouldn't complain about cancer or heart disease because, after all, they warned you on the boxes. But on the other hand, they say, we don't know what causes cancer, heart disease, and so forth. And I think what eventually will tip all this business is when some judge is honest enough to assess the internal memoranda in the cigarette companies and know that for years and years and years they have known about the addiction to nicotine and about all the health hazards, and they have methodically hidden those from the American people and have advertised just the contrary and put cigarette advertising in such a way that it is always depicted with a healthy lifestyle and marvelous young people who are enjoying life, and that just isn't true.
as a woman, as a physician, as an obstetrician gynecologist, and as a member of the Public Health Service Reserve, Dr. Coop, I'm actually addressing this question more to Dr. Albright, but to you too. I'm particularly concerned and upset about the statistics regarding women and girls taking up smoking, finding it harder to quit, and lung cancer death rates exceeding breast cancer as a leading cancer cause of death for women. Do you think that we could form a coalition of women physicians, women health professionals, speaking to young women, to teenagers, to grade school girls, with perhaps your Olympic contacts, Mary Lou Retton, some other gymnasts, and a few rock stars and models, and using the same techniques that are being used to glamorize cigarettes and make them seem a way to be sexy and slim, and show that health is a better way to be sexier and slimmer. In conjunction with Dr. Coop's contacts in Washington and departments of education and substance abuse, could we address and focus some work targeted to young girls, grade school, 5th grade, 6th grade, junior high, and how could we do this most effectively?
You've hit something very close to my heart. I feel very strongly that one of the things that we've got to change in medicine in general is to somehow have more time to focus on the preventive aspect and to get the message into the grade school and education at a time when youngsters are interested in how their bodies work. They want to know about emergency situations. They're curious, and I think they'd be very interested. I think your idea is a wonderful one. I just wonder if perhaps some of the grade school children and teenagers might not be almost put off by seeing Mary Lou Retton. Most of us can't do her double upside down flips and everything on and off the balance beam and over the horse and everything. Anyhow, we know we never could. Perhaps as an example, but then bring it back to some of the people that they feel they can be at any time and are now. But I think that's a wonderful idea. I would love to see all of us in medicine have more focus on not needing medicine, not getting sick, not depending on pills, and even as a surgeon staying out of the operating room.
There's a new innovative thing about to take place and will be launched in this country in the middle of October, and it comes from the Coalition on Smoking or Health, which is American Heart, American Lung, American Cancer. And in my call for a smoke-free society by the year 2000, they took on the obligation of trying to graduate a high school class that was smoke-free before the turn of the century. And this new program is aimed at just the people you're talking about, but it doesn't limit it to girls. It's girls and boys. And it does exactly what you suggested, and that is that we're perhaps have been focusing a little bit too late in adolescence. I'm convinced that an 8-year-old has made up his mind he's going to smoke. He won't smoke then, but in his mind he said, as soon as I can, I will. And therefore, I think you have to get at him before he's 8 years old. So that I think that's an extraordinarily important endeavor that the coalition is going to carry out, and I look forward to some major successes in this regard.
I'm sorry to leave some of you standing at the microphone, but I've been handed a note saying that that was the last question. I want to thank our panel members and the audience for participating so vocally. And now I must ask you, when you leave, to leave quickly and to leave through these doors on my right, on your left, out into the park so that they can set up for the next symposium. Thank you very much.